Hello and welcome to the Thoracic Surgery Clinics podcast. Thoracic Surgery Clinics is a quarterly publication from Elsevier, consisting of review articles centered on a major topic important to general thoracic surgeons. I'm Megan Ashdown, managing editor of the series here at Elsevier, and we'll be discussing the May 2025 issue devoted to pulmonary metastasectomy. Leading the discussion will be our consulting editor, Dr. Virginia Lytle, Director of Thoracic and Foregut Surgery at the Sutter West Bay Medical Group in San Francisco, California. Joining her will be the guest editors of the issue, Dr. Mara B. Antonoff, Associate Professor of Thoracic Surgery at the University of Texas MD Anderson Cancer Center in Houston, Texas, and Dr. Smita Sehag, Assistant Professor of Thoracic Surgery at the Memorial Sloan Kettering Cancer Center in New York, New York. Welcome, and over to you, Dr. Lytle.
Welcome. Thank you for joining today. I'm going to just say our May 2025 issue of Thoracic Surgery Clinics is about pulmonary metastasectomy, and kindly MD Anderson Associate Professor of Thoracic Surgery, Dr. Mara Antonoff, and Assistant Professor of Thoracic Surgery at Memorial Sloan Kettering Cancer Center, Dr. Smita Sehag, composed a diverse list of topics from surgical resections to additional management approaches for these advanced stages. So, doctors, thank you again for guest editing this recent issue of Thoracic Surgery Clinics. We could have discussed many wonderful contributions from your invited authors, but I have some questions for you about several select topics from the issue. But before we get started with those questions, I'd like to ask you a couple of things about you and your practices. So, starting with Dr. Antonoff, how did you develop a particular interest in management of metastases to the lung? Maybe because you're a thoracic surgeon, but I suspect there are some other factors. And maybe you can also expand a little bit about your research interests in this area as well.
Yeah, absolutely. It's a real pleasure to be here. And I think, we as thoracic surgeons naturally see a lot of patients with pulmonary metastases. It's one of the most frequent sites of metastasis for a number of different primary tumors. But I think, many of us recognize that there are a number of unanswered questions when it comes to pulmonary metastasectomy. Who benefits the most, and how do we best interplay with systemic therapies? What is the efficacy of surgical therapy compared to some of the other local treatment modalities? I think for me, it's just the recognition that many of these really advanced stage diseases affect patients who may be very early in their lives and really are looking for the most aggressive form of therapy. I think we too often view malignancies as being advanced, being stage 4, and really limit patients' opportunities potentially either to look for a cure or to really have a break or a respite from systemic therapy. And my research has, of course, looked at outcomes, recurrence patterns, and increasingly translational opportunities. I think ultimately we really need to understand how we can best inform precision medicine by really offering patients the right combination of therapies and in the right order so that we can best think about aspects not only about disease-free survival, progression-free survival, prolonging their lives, but limiting the elements of time for how long they have to be on systemic therapies that really may impact their quality of life. So I think it's a really fantastic area that combines both our surgical nuances with collaboration across other specialties and innovation to help patients who may otherwise have rather limited options.
Yeah, I think that's a great answer and an excellent approach, and the fact that you're caring to these people that a lot of surgeons just write off, and say, go get chemo,
Right.
or systemic therapy. Dr. Sehag, as you work at another major cancer center of excellence, do you all regularly review these types of often complex cases at your tumor board before any treatment starts, and then you can offer a multidisciplinary approach?
Yes, absolutely. So we have a at this point in time, we have like a separate section almost of our tumor board devoted to oligo cases and and cases that are eligible for local consolidative therapy. So basically, our tumor boards are divided by disease type, whether it's lung cancer or other cancers. But we certainly have a multidisciplinary discussion for many of these cases, especially the more complicated ones, uh, where it may have been more widespread metastatic and then downstaged, or even just oligometastatic. More sort of straightforward solitary mets with certain histologies. I mean, we don't necessarily have to discuss all of those, but many of these are a little bit more tricky. And if we want to employ some hybrid approaches, which we'll talk about shortly, those are certainly cases that we want to discuss in a multidisciplinary fashion.
Yeah, that's good. And just out of curiosity, do some of your translational researchers like PhDs who are studying like circulating tumor DNA, do they come to the tumor boards?
So my research fellow does come to some of the tumor boards, but is it routine? No, it's not.
Yeah.
But yeah, great that you mentioned ctDNA, as I think that will be an important tool to help us figure out, what the disease burden is in these patients truly, and whether or not local therapies are appropriate to deploy.
Yeah, it comes up like weekly at our
Yeah.
lung tumor board. But I think it's still evolving and how you use it and how accurate it is.
Yeah.
Yeah. So, Laura, do you have a comment?
I think, like you said, we know that when it is positive, that it may have some meaning. When it's negative, we don't know what it means.
Yeah.
And really, the coordination and integration of our imaging findings, um, our lab assays, everything that we can put together can help guide us. But I think, you've both hit on the important aspect that multidisciplinary discussion is key. We actually do not talk particularly about other sources of malignancy that have spread to the lungs at our thoracic tumor board. They tend to take place at the tumor boards for each of those disease sites. So we sometimes have to be willing to go to those other tumor boards, which is certainly a lot more easily facilitated in an era where so much of what we do can be done through a lot of our online platforms rather than necessarily running from one department of the hospital to another. But I do agree that all these multidisciplinary discussions are incredibly valuable in understanding what different options exist for the patients and helping in folks who don't typically deal with the lung itself understand really the differences in treatment modalities that are available for the lung itself and how different local therapies can impact the lung and patient experiences, because it may not be something that the team taking care of that disease site is typically accustomed to.
Okay, now we will get into some of the submissions in this clinic's issue. Dr. Seahog, you invited your memorial colleagues, Drs. Chu, Yariv, and Gomez, to co-author with you a submission entitled Hybrid Approaches to Local Management of Pulmonary Metastatic Disease. Can you remind our audience the basic indications in 2025 for resecting pulmonary metastasis? And I believe it's evolving and not always restricted to patients with no extrathoracic disease.
Yeah, absolutely. So, some basic indications that are also mentioned in the STS expert consensus document. Um, and I kind of look at them not as hard indications, but as, as guidelines on who, identifying who's going to benefit from this type of more aggressive approach. I think number one, you want to have good control, or ideally even removal of the primary tumor. I think most patients with renal cell colorectal cancer, sarcomas, et cetera, have had their primary tumor addressed definitively with surgery. But primary tumor control is important to consider because what's the point of pursuing Mets if you still have tumor in the primary site? So that's number one. Number two, the lesions should be, ideally completely resectable with an R0 resection. And if they're not completely resectable, then all should be amenable to some form of adequate definitive local therapy. So I think those two are sort of the most fundamental principles for pursuing metastasectomy. Others that are, again, as you described, a little bit more evolving, extrathoracic Mets are controllable or controlled. So for example, many patients with metastatic colorectal cancer will come in and they will have had some liver Mets too, or something of that nature. So those need to have been addressed or have a plan to address them or be stable over a period of time to, I think, justify pursuing, surgery for metastatic lesions to the lung. And then obviously the patient needs to be a candidate for surgery. A few other things you can think about in terms of who might benefit most, we think about, 3 lesions or less, probably more likely to be, potentially curative or life prolonging. In those scenarios, am I and many other surgeons I know guilty of removing, up to 10, 15 Mets from young patients who are fit, who want a break from therapy and want some, extra time and hope. Yeah. That is done, and I've done it myself. But I think in terms of the ideal patient population that we want to target with this type of approach, those would be really the indications that we're thinking about. Other things to keep in mind, disease-free interval is another thing that crops into my mind in terms of how quickly did these come on. Should we follow a little longer before making a final decision to resect? Things like that. But those would be the first few I mentioned are truly, I think, the fundamental indications.
It's evolving, but we also are applying some of the traditional indications from like 20 years ago. Um, so second question for you is for percutaneous ablative therapies for lung and liver lesions have been around for a while. RFA, cryo, microwave ablation. Are these all still in our armamentarium? And can you expand on the role and pros and cons of this other new technology, pulsed electric field option?
Yeah, sure. So I'll tell you, Jenny, so obviously, I think we want to consider surgery as the first line possible therapy for pulmonary Mets in a candidate, someone who's a candidate for surgical resection. So that's kind of first in my mindset, obviously, as a thoracic surgeon. And then I start to look at, how much needs to be resected? Are there other lesions? How many resections are they going to require? Can they really get through that? Should we just do one side with surgery, kind of more progressive lesions? Sometimes you see these oligoprogressive cases where there's some stable disease, but then there's disease that's acting up, and you really kind of want to go after that with surgery and then start applying other modalities. I'd say regardless of histology, my usual second line modality is SBRT. That would be usually my next recommendation if I'm not going to resect or if we need to take a more hybrid approach. And so SBRT. And then comes these ablative therapies, which I have to say are my last line of therapy, local therapies to offer. I think that radiofrequency ablation, which is what's most frequently done at our center, is reasonably effective for certain lesions, as long as they're relatively small. Pulse field uh, ablation is something that's used, I guess, more frequently in the cardiac realm for like arrhythmias and so forth, but it does apply here where it can be used to treat cancers that are, tumors that are in tough locations near a nerve, near the heart, et cetera, to reduce toxicity. And I think that those are really the situations where I've seen our teams use that particular modality. But I personally am not aware of a ton of data out there on it for many histologies, and again would not be like one of my even my first or second go-to there.
I know you can find them at a booth at SDS and AHS for the audience to know. Okay, moving on. Dr. Antonoff, you all, both of you, invited an innovative surgeon, Dr. Ian Bostock at Miami Cancer Institute, and he invited resident Kevin Huang to co-author. And they wrote about metastasectomy and the role of collecting tumor infiltrating lymphocytes, TILs, from the tissue. This relates to our future issue about precision medicine. What is this adoptive cell therapy the authors write about?
That's a great question. We have a very large practice of the TIL therapy in our institution, and the adoptive cell therapy is when you use the patient's own immune cells, so the tumor infiltrating lymphocytes, which are harvested from the tumor, and then those cells are expanded in a laboratory setting and then reinfused to help fight the cancer after the patient receives really high dose chemotherapy in the inpatient setting. And it's been really extensively proven in melanoma, and now it's being studied in a number of other primary tumors. And so we have the opportunity as thoracic surgeons often to harvest some of these sites of metastasis so that the tissue can be used for the expansion of the cell population for subsequent treatment.
It is available at certain centers, but obviously not everyone has the infrastructure to be able to apply yet, unfortunately. How much tissue do you need to move forward with this therapy? And do you always have to do a surgical excision of tissue, or are they moving towards maybe getting it by robotic bronch or percutaneous, true cut biopsy?
Yeah, it's a great question. So this is a little bit different than other procedures that are done for getting tissue just to look at under a microscope. This is a situation where you're trying to get an adequate number of cells, and the process for expanding these cell populations is pretty resource and time intense. So you definitely don't want to have a situation where you don't have enough cells. And so I've been involved in several protocols at our institution that involve harvesting TILs for subsequent treatment. And regardless of whether it's our standard of care TIL or some of our studies, typically the recommended volume of tumor is ranging from 1.5 to 4 cubic centimeters. That's definitely quite a bit more than you could ever get even from a core needle biopsy. Yeah. So I mean, it's with the understanding that you need a larger volume, and even still, I tend not to be satisfied with getting even just something that's exactly 1.5 cubic centimeters, because you don't know how much of that nodule is going to be all tumor cells versus maybe some necrotic cells and whatnot. So in general, though, it's recommended 1.5 to 4 cubic centimeters for those types of therapies.
Dr. Seahawk, do you guys do this at Memorial?
Yes. There are a couple of people in our group that are a bit more dedicated to trying to figure this out. But this approach is, more often being investigated for lung and meso and these types of things. Less so metastatic tumors to the lung.
Dr. Antonoff, a hot and important topic is disparities in healthcare delivery. So moving on to another topic, you asked MD Anderson colleague Dr. Ravi Rajaram, and he's actually going to guest edit an issue, I think, next year on chest wall lesions. And he invited, at the time, research fellow Shanique Rees to write about disparities in pulmonary metastasectomy. No one really thinks about this, but we know there is an abundance of literature regarding inequity in other areas that we deal with, like lung cancer screening, resection rates for esophageal cancer. So, what are the underlying causes of disparities in pulmonary metastasectomy?
Sure. I think that's a really important question because we often think about disparities as they relate to treatments that maybe are more standard of care or more clearly approved without as much ambiguity or as much gray zones. And so I think when we start talking about patients who may have a disease that's been traditionally or historically thought of as being less amenable to local treatment. People who maybe have a disease where it may have been more the standard in the past, not to write them off, but to really have patients settle for systemic therapy until something else comes along. I think this is where we see even more disparities. So yes, like anything else, it can be due to access to specialty care and insurance and geographic and referral barriers. But ultimately, I do believe there's some extent of implicit bias and variability in provider recommendations, and patients may not always be offered surgery even when eligible. But it's definitely multifactorial. There's going to be elements related to the types of hospitals where people are being seen, insurance status, education level, and payer status. And then these areas of implicit bias that we don't totally know and understand. And some of these things are addressable in through education and more straightforward strategies, and some are larger, more complex systemic issues. But I think being aware of it is incredibly important because oftentimes just that awareness is a huge step in making a difference or making progress.
I think it's very important because we know all three of us have seen what goes on at community hospitals, from just doing a lung resection for primary lung cancer and not even sampling the lymph node stations and all that. But we also know that a lot of community hospitals, they don't even try to prove what stage the cancer is. They just say something is PET positive and, oh, they have stage 4 disease, like a bone or some lymph nodes or something, and they don't even prove it. But so I think it's key, I have had some publications on this, going out to like rural areas or community hospitals and educating the folks that are taking care of these cancer patients, the medical oncologists, and maybe diplomatically attending tumor wards and just bringing things up, and also in a tactful way, of course, not like I'm a fancy surgeon working at a big cancer center and that you guys need to listen to me. But no, you try to work with these people. So, but that's one way to improve disparities for these outlying hospitals. But also, I'm not sure the best way to alleviate the fear of patients. I mean, I've had patients when I worked in a safety net hospital in Boston, and they're like, well, God's making the decision for me, and that's it. And I'm sure you guys have heard that before over the years. Yeah. So.
Yeah. I think you've highlighted, certainly the importance of educating providers and strengthening the referral pathways to facilitate giving access to this really, more options for care for patients, really, regardless of where they're receiving their care. And we certainly recognize that there are patients who may not choose surgery, but a patient can't choose surgery if they're never given it as an option. So educating providers, strengthening referral pathways, providing education to the patients, I think is incredibly important. Other ways I think that we can address these imbalances in care are to broaden trial enrollment to include diverse populations,
Yes.
and really to try to emphasize the idea that every patient who has a disease that could potentially be treated by a thoracic surgeon should be evaluated by a thoracic surgeon. And we can't be unwilling to see patients and tell them that they're not surgical candidates. That's part of our job, so we don't necessarily want patients being screened by other specialties to determine if something is resectable or if the patient is of adequate physiologic status to undergo lung surgery. And so I think us being engaged, involved at our own institutions and elsewhere is really kind of the best way that we can try to address some of the situations where patients might be candidates and aren't being offered the same opportunity.
Yeah, I concur. And I assume you all have nurse navigators at your hospitals to, after you see the patients and maybe they don't know how to facilitate getting the rad-onc appointments, or they have no way to get to the rad-onc appointments. And I think nurse navigators can help with the inequity or disparities in healthcare delivery too. But I assume you guys have that in your at your hospitals, right?
We don't have nurse navigators for this specific
Oh,
purpose. We do have nurse navigators for getting patients into some of the systems, some of the different treatment pathways. I think it's really on us to some extent to ensure that patients are being evaluated by a multidisciplinary team. And if I'm seeing a patient with pulmonary metastatic disease, I think it behooves the patient and it's on me as well to say there are other strategies for which these nodules might be treated. This may be best treated with a hybrid approach. Maybe, we'll operate on your left lung and radiate the right lung, and, being able to talk to them about all of that. And I think really ultimately it's on us to communicate with the patients that we are all working together to provide them with the best outcome, and to not just say it, but to actually mean it, to communicate with the other care providers and to ensure that they're seeing everyone, and for us to connect with the other providers before the other visits and after the other visits, and to be able to give patients honest information about recurrence and disease-free survival based on the different modalities. I mean, we have comparative studies of, for example, surgery versus radiation for colorectal metastases, but there are benefits and drawbacks of each of those therapies. So I think just the more information we can give them, and the more that we can explain to them the importance of a multidisciplinary team-based approach rather than just, explaining to them the hammer that we have for their nail, is probably going to be the best strategy. I am aware of nurse navigators that facilitate this process in some facilities, but I think we all need to be able to help make it happen regardless of whether or not there is a nurse navigator present.
you're right. I think a lot of surgeons, not all surgeons, really reach out to patients beyond the visit and immediately post-op. I think we have to remember we are physicians and surgeons, so be sensitive and communicating with our patients. So, Dr. Seahog, another contribution I'd like to ask you about is the reoperative pulmonary metastasectomy. Authors from various institutions, including Drs. Briasco, Bansal, Subramanian, and Bograd wrote about this topic. Well-enough folks do not like reoperations in particular on their chest. They go through it once and they're like, I have lung cancer on the other side. I'm getting SVRT. Forget that. Because they can't handle the pain. But please share your thoughts on indications for a reoperation and if there are particular histologies that are more amenable to this approach. Historically, sarcoma could actually cure people, taking out pulmonary mets, not sarcoma. But maybe there are other malignancies we should be aggressive about as well. Can you comment?
I think that,
for reoperative pulmonary metastasectomy, in general, I'd say the indications are similar, to undertake it the first time, whether or not to undertake it again. But I think that the points you bring up about certain histologies, and then I would also add certain biologies, should be under consideration when undertaking a second operation to remove Mets. So for histologies, we think about sarcoma in particular because there really aren't other good options. These tumors don't really respond to systemic therapy very well, and nor do they really respond to radiotherapy. So certainly tumors, certain histologies where there are limited additional options. People have already gone through multiple lines of systemic therapy, et cetera. Those are reasonable to consider. And the other thing that I think really needs to be considered is the biology of the disease, and in particular, the disease-free interval. Should you be going back in 3 months later to remove more Mets? Not sure about that one. That make me feel a little uncomfortable. Probably not a great idea. However, 2 years later, someone's showing up with additional Mets that need resection. That starts to become much more reasonable in terms of understanding that the first metastasectomy, did provide benefit. It worked. It's worth pursuing again. Obviously, as you mentioned, you got to convince patients to do it again, and get them through to make sure that they're operative candidates. But I think histology and biology are really the important factors to consider here if you're gonna take somebody back to the operating room to take out more Mets.
Would you be able to summarize the SDS expert consensus task force recommendations for reoperation?
I believe that they do still center around a few fundamental principles of, control of primary tumor, control of extrathoracic disease, and ability to achieve R0 resection or definitive local therapy to all metastatic sites. There's more discussion about operative risk. There's more discussion about disease-free intervals, as I discussed in terms of you know, uh, making sure that the patient has a higher chance of benefiting from taking them back to the operating room to resect more Mets. If they've had a very short disease-free interval, that's probably not the case, but
Yeah.
a longer one certainly is very reasonable.
Yeah.
Anything else I missed, Marv?
No, I don't think so. I think, much of it is related to the recommendations for the primary operation, which is that, multidisciplinary evaluation required, that remembering that repeat resection is feasible and safe. Not all non-thoracic surgeons or non-surgeons recognize that it's something that we can do. And again, the emphasis on parenchymal sparing approaches, consideration of the non-operative therapies, and recognizing the technical issues that can occur when there has been prior operation. And ultimately, I think just like the initial operation, the transparency with the patients about the limits of the evidence that we have present and counseling them appropriately are incredibly valuable. And I think that the STS recommendations really kind of highlight that many of the considerations are the same as the index operation, and it's kind of the onus is on us as the technical expert to educate the rest of the multidisciplinary team about the feasibility of the operative procedure.
Precision medicine is also going to play a role as we evolve to do more reoperative pulmonary metastasectomies. Do either of you have comments on where that is going? And we talked a little bit about the circulating tumor DNA. Do you guys also look at cell-free tumor DNA or?
Yeah, I can start on that one. So obviously, as our therapy becomes better and more precise, we're going to be able to downstage some patients and make non-surgical patients become surgical patients. I personally don't think surgery is going anywhere. I don't think any of these drugs are good enough to reliably cure patients across the board. So I do think that the majority of patients who respond to these medications are in the boat of becoming downstaged to the point that they are amenable to local therapy. And so obviously the number of metastasectomies that we're doing now in our practice is much higher than I'd say probably 5 or 10 years ago, and continues to increase as time goes on. Cases that you never thought you would be seeing again. In terms of circulating tumor DNA, I think that at least the way I'm thinking about it, and what our data is suggesting, is, just as Mara mentioned, positive result is helpful, a negative hard to interpret. And I would just go a step further to say that the positive to negative conversion is what I think is the most informative for these oligo type cases where they started out positive, they got treatment, they got converted to negative, they still have lesions on a scan. I feel that I personally think that these patients probably, have achieved some degree of systemic disease control to the point that they will probably benefit from local therapy. And it could allow us to better identify those patients and give us more assurance that local therapy is actually going to, be more effective in that patient population. So that's our kind of initial thought on it.
Oh, that's excellent. I'm glad you guys are investigating this area and have such busy volume that it helps you make progress. Although I hope we're not impacted by decreased funding. No. Anyway, any final thoughts you all would like to share on this topic of pulmonary metastasectomy? Dr. Anshoff?
I just think it's terrific that we were able to put together a collection of articles really addressing these separate issues, these separate questions and clinical challenges in pulmonary metastatic disease. We tend to lump all of these nuances into one chapter in any book, and it's really so much more complicated and so many different elements related to the considerations for caring for these patients. So I think this is a really phenomenal opportunity to provide really specific education to our colleagues in each of these areas. So I think there's certainly a lot more research to be done. Dr. Seahag is certainly doing some great work with a lot of the ctDNA and other molecular markers for these patients, but I'm just grateful for the opportunity that we could elaborate so many of the details in this issue.
Yeah, I appreciate that. And Dr. Seahag, do you have anything else to say?
No, really, I just want to thank you both for inviting me to be a part of this. And I hope that the readers can benefit from, a lot of the knowledge that many of the authors have put forth, and continue to kind of think of ways to push the envelope in this space. So, yeah, thank you both very much. And thanks for having me here.
Well, thank you. And thanks to all the authors for their time and contributions as well.
Thank you for joining us for this Thoracic Surgery Clinics podcast. For an exclusive discount on the issue we discussed today, focusing on management of the trachea, visit us.elsevierhealth.com/expert. Thoracic Surgery Clinics is available for individual print subscription with accompanying online access, or individual online-only access, and is also available on the Elsevier electronic platforms, Clinical Key and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to the Thoracic Surgery Clinics podcast wherever you get your podcasts. Until next time.